Okay, assalamu alaikum everyone. My name is Lara Samhan, and today, inshallah, me and my friend Bushra will all the way start off with the GIT Physiology review session. So basically, in this session, we're going to review many questions, like GIT related questions, and inshallah, you guys will have clearer concepts and will just clear all of your confusions throughout this questions. And if you guys have any question throughout the session, please feel free to ask. And if you have any question all the way after the session, you kindly have our emails and our contact numbers. Just please feel free to contact us anytime. And of course, we're more than happy to help. Okay, so let's all the way start off. So basically how we're gonna run this session is I'll just display the question and you guys can just say whatever answer you would like. And then we're gonna inshallah discuss the correct answer after that. So I'll start off by displaying this first question. You guys can have take your time reading it, inshallah. And then after that, inshallah, you can just give whatever answer you think is correct and we're gonna discuss it. So let's start off with the first question. What do you guys think is the answer? Okay. Yes, mashallah. Perfect. So basically the question says most of the gastrin released following a meal is from which of the following structures? As we know, gastrin is basically a hormone, right? So from the word itself, gastrin, so it's going to be produced in the gastric or in the stomach itself. So where is it going to produce? It's going to be available in the stomach or in the GI in general. So where is it going to be produced? It's going to be produced from the antrum. As you kindly said correctly, mashallah. So basically, we have in here that the choices is antrum, colon, duodenum, jejunum, and ileum. So as we know, that duodenum, jejunum, and ileum, those three are basically parts of the small intestine, starting off duodenum, jejunum, and then ileum. And then after that, after the small intestine, we have the colon. And before all of those things in the stomach, we have the antrum. So as you guys kindly said, mashallah, the correct answer is A, which is antrum. So in here, we basically have a section of the stomach. As we can see, this thing is the stomach, this is the esophagus, and this is the duodenum. The beginning part of the stomach is basically the fundus, and this is the body of the stomach, and the stomach ends off with the antrum. And as you can see in here, this is the G cell, or G cell is basically the gastrin, tamam. It's basically where acid is also being produced, or where the HCl is being produced. So as you guys kindly said, the correct answer is antrum. And this is where basically the G cells or the gastrin is being produced. Is it clear?
Yes, it's clear. Thank you.
Perfect. So I have another picture in here. This is exactly the same thing, but it just looks like a bit more. So basically we have in here, this is the stomach. We have in here different parts of the stomach have quite different cells. Some of them are the parietal cells. We have also the G cells and many more other cells. Some of them secrete HCl. Some of them inhibit the secretion of HCl. So basically, as we can see in here, this is the stomach. And the end of the stomach is basically the G cells, or at the end of the stomach or the antrum is basically the G cells. We also have some of the G cells like in other places, but mainly the G cells are available in the antrum, tamam? So as we can see in here, G cells produces gastrin and it basically aids in the production of the HCl. Also, we have the parietal cells produce HCl. So basically, the stomach doesn't only depend on the parietal cell to produce HCl. No, it has the parietal cell, it has the gastrin cells, and many more other cells. Tamam. So let's move on to the second question. What do you guys think is the answer? You can take your time. Okay.
Duodenum.
Yes, exactly. You can write in the chat, don't worry. Yes, mashallah, you guys are perfect. Exactly. So here we have the slow wave frequency is greatest in which of the following? So the slowest wave among us, the whole GI tract, it can be actually available in the duodenum. As we can see in this picture. So basically, why the duodenum? Because usually in the stomach, the cycle is basically, it takes 3 minutes. Compared to the duodenum, the food actually can stay in the duodenum for 12 cycles per minute. So because of that, the duodenum is having a slower frequency compared to other parts of the GI, or to be more specific, compared to the stomach. Tamam. So moving on to the next question. You guys can take your time. And what do you think is the answer? Any guesses? Excellent. MashaAllah. Perfect. Exactly. So this question basically says that we have the gastrin, the cholecystitin, secretin, the motilin, and the glucose-dependent insulinotropic peptide are secreted from endocrine cells located in which of the following structures? As you guys kindly said, mashallah, it's the correct answer is the duodenum, and here I have some of the explanation. So basically, as we know, some of those hormones are produced either from the stomach or from the duodenum, but the thing that basically this question mentioned is mostly produced in the duodenum. And here we have some of the, this basically table summarizes some of the important hormones that are available in the GI tract, to be more specific, in the stomach and the small intestine. So this thing basically aids in the either HCl production or bicarbonate production. And basically we have like the importance of HCl production and bicarbonate production is to help in ingestion. As we know, the stomach, for the food to be basically ingested in the stomach, we need more of the HCl or the acid production so that it gets ingested. And in the small intestine, starting off with the duodenum, we prefer to have more of the alkaline or the bicarbonate environment so that the duodenum won't get, for example, having ulcers or other like diseases. And plus, the duodenum and the small intestine doesn't have the protective layer as the stomach has from the acid. So because of that, always acid, always the stomach is preferred to be having an acidic environment, and the duodenum or the small intestine in general is preferred to be having a alkaline environment. Okay, so in this table, we basically can see some of the GI-related hormones, starting off with the gastrin. As we said, gastrin is produced in the antrum in the stomach. In the antrum, the end part of the stomach, so it's going to be produced in the stomach, and it basically helps in the HCl or the acidic release, tamam. Compared to the secretin, secretin is almost the opposite of gastrin. It basically likes alkaline environment and it's produced from the small intestine. To be more specific, in the target organ is basically the pancreas, and the source is the duodenum. So it likes the alkaline environment. So gastrin and secretin are almost exactly the opposite. Gastrin likes acidic environment compared to the secretin, which basically likes the alkaline environment. We also have the CCK. It's also produced from the small intestine, and it also likes the alkaline environment. And lastly, we have the GIP, which is basically helping in the insulin secretion. So these are like some of the hormones or that are basically produced from the GI tract. Okay, so moving on to the next question. What do you think is the answer?
C.
Exactly. If you would like, you can type in the chat. Perfect. عشان ما يغشوا منك. Okay, perfect. Exactly. You guys, most of you basically got it correct. So basically the correct answer is C. This question says an oral glucose load is cleared from the circulation more rapidly compared with an intravenous glucose load. So the interesting phenomena can be attributed to the action of which of the following. Once you hear the word glucose, like anything, none of those like hormones or enzymes in general can actually like help in the glucose metabolism except for this thing, the glucose-dependent insulinotropic peptide. It significantly helps in the glucose metabolism in the body. So an easy way to just like know it, here we have glucose, and of course one of the choices or one of the correct choices should be something in related to glucose. Okay, so this is like an easy way you guys can just get it correct. Tamam. Okay, perfect. So as we said, this GLIP helps in the glucose metabolism. Perfect. So let's move to the next question. What do you guys think is the answer? Perfect. Excellent. Yes, salam alaikum, mashallah. Yeah, you guys are really, mashallah, you're so perfect. Exactly. So this question says biopsies are taken from the antral and duodenal mucosa of a 45-year-old man. Which of the following hormones can be found in tissues homogenates from both locations? So, as you guys kindly said, it's going to basically be produced, or the hormone is basically the gastrin. So, as we know, the gastrin is basically going to be produced from the stomach, to be more specific, from the antrum of the stomach. Perfect. Okay, moving on to this question. It's more to histology related. You can take your time. Excellent. What do you guys think? Yes, salam alaikum. MashaAllah, excellent. Exactly. So basically this question says if one cuts through a segment of a small intestine. So now we're taking a cross section of the small intestine, not the large intestine, not the stomach. We're talking about the small intestine from outside into the lumen. Also, it's important to like be aware, is it from outside to inside or vice versa? Because sometimes the question changes even though you know the correct answer, but sometimes you mix up, is it outside to inside or inside to outside? So it's always like better to be aware, like what is the order? Is it out to in or in to out? Okay. And this is by the way, not only in this block, in all blocks in general. It's quite important to like know, is it like the orientation from out to in or vice versa? Okay. So here it says from outside to inside or to the lumen, and in which order would the layers be? Be the wall, like how the layers of the wall will be cut. And as you guys kindly said, it's basically E or number 5, which is starting outside to inside. So outside we're gonna have serosa, inside we're gonna have the mucosa. So we're gonna start off with serosa, longitudinal smooth muscle, minor plexus, submucosa, and mucosa. What does submucosa mean? Sub means below or behind. So submucosa will be behind the mucosa. And the innermost layer of the small intestine, where it actually gets in direct contact with the food, is the mucosa. We also have here a cross section. So basically, this is a cross section of the small intestine. As we can see, inside is the lumen, and here we have some of the epithelial cells. So this question told us from outside to inside. So we want to start all the way from outside from here, all the way to the inside, which is to the inside of the lumen. So starting off from outside, as we said kindly, we're gonna start off with the serosa, all the way moving inside, we're gonna have the mucosa. تمام. Here's the mucosa, and outside is the serosa. So the mucosa in here, as we said, below the mucosa is basically submucosa. So sub means below or behind. So the mucosa in here, it just says what are the layers of the mucosa. We have in here the submucosa, muscularis mucosa, and the lamina propria. Okay, so you guys got it correct, mashallah. So moving on to the next question. Perfect. لا 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 ما شاء الله, you guys studied. You guys, mashallah, really so clever, mashallah. Exactly. So the correct answer is basically number 4, which basically the question tells us we have a clinical experiment that's basically being conducted in a group of subjects that's basically given 20 grams of glucose intravenously, and another group who's basically being given 20 grams of glucose orally. Which of the following factors can explain why oral glucose load is cleared from the blood at a faster rate than the intravenous glucose load? And here just explain the like the terms, what the CCK stands for, GLIP, and the VIP. So as we said, this question is basically, even though it might seem a bit long, but it's talking about glucose in general. And not really, none of this really talk about glucose as much as number 3 and number 4 does. So basically number 3 says GLIP, induced glucagon release, and the insulin release. We mainly care, like as we know, insulin's main function in the body is basically to decrease or try to maintain normal glucose in the blood, right? So those basically patients, or those sample, like a group of patients took glucose, and we want something that decreases or maintains like a normal glucose level in the body, and this will be aided by the insulin, not the glucagon, because as we know, glucagon increases glucose levels in the body. So because of that, the correct answer is insulin, something with insulin, and it's basically the GLIP. So this answer is the correct answer, which is number 4. برافو عليكم ما شاء الله. Perfect. Okay, moving on to the next question. What do you guys think is the answer? Okay, any guesses? Okay, correct, exactly. So the correct answer is histamine. The question says the stimulatory effect of gastrin on acid secretion are mediated in part by gastrin-induced secretion of which of the following substances? So as we know, gastrin is basically will secrete gastrin will basically exactly salam عليك, gastrin histamine axis exactly. Gastrin is going to secrete HCl. Same goes all the way to the histamine is going to also secrete the HCl. And as you kindly said, we have the gastrin-histamine axis. So gastrin secretes HCl, histamine secretes HCl. So once you see the word gastrin in this question, even without continuing the end of the question, خلاص, you'll know that it's talking about gastrin, so it will be most probably histamine. Okay, so we have in this figure, basically, it just shows like a mini figure that basically just shows that how histamine can basically help in the secretion of HCl, same as the mechanism of action of the gastrin. Perfect. Moving on to this question. Perfect. يا سلام ما شاء الله. Excellent. Any other guesses? Okay, perfect. تمام. So this question says, which of the following basically leads to a decrease in salivary flow? For example, if somebody's gonna chew, during chewing, as we know, the saliva, exactly, the saliva flow is gonna all the way increase, right? Because of the like hormonal effect plus like the physiologic effect of the body. So chewing is gonna increase the salivary flow. Because of that, it's easily, once we eat anything in normal individuals, once they eat anything, it's gonna all the way, they can easily chew it and like swallow it. Also, nausea can also increase the salivary flow because like nausea and vomiting is gonna increase the salivary flow. Same goes to if there's any smooth object in the mouth, smooth object, rough object, any object in the mouth in general will help in the salivary flow, except for fear, because fear, as we know, it's fight or flight, and it's a sympathetic response. So the body is not having time to just keep on producing saliva. Like it has way many more other like significant things to do during a fight or flight response. Producing saliva can be like during relax and everything, you can produce saliva. Now, especially during fear, during fight or flight, we don't want saliva, we don't want anything insignificant, okay? So this is why salivary response or salivary flow is going to be the least in fear or in like any fight or flight situation. Perfect. Okay, moving on to the next question. Exactly. Any other guesses? Perfect. Okay, so this question is quite easy and straight. So the only voluntary phase of swallowing is basically either A, B, C, D. The correct answer is C. Why? Because once we basically have for the swallowing phase or the voluntary phase of swallowing three phases, starting off with the oral phase, then the pharyngeal phase, and lastly we're gonna end off with the esophageal phase. And by the way, guys, this is quite important not only in GIT of first year, it's also important in GIT of third year. They almost take the exact same thing. And this came a question in third year exam, SAQ. So the question was like, what are the voluntary phase of swallowing? So it was a three, tamam. So we start off with oral, then pharyngeal, and lastly we're gonna end off with the esophageal phase. Perfect. So the oral phase is the only phase that's voluntary. Why? Because we have the muscles in here, the tongue and everything is a voluntary muscle. So you can easily, for example, if you don't want the food, you can remove it out. If you want to swallow it, you can definitely swallow it and it's gonna all the way go down. Once it reaches to the pharynx and to the esophagus, it becomes quite involuntary, except if the body wants to just remove it out, like by a vomit or by a reflex mechanism. That's the only thing that can remove it out, okay? Other than that, the oral phase is considered a voluntary phase. So as we can see in here, the three phases of swallowing, this green thing is basically the bolus of food. It starts off with the oral phase in here, and then the food moves down a bit. So as we can see this picture, it moves down a bit, which is the pharyngeal phase. And lastly, it ends all the way off to the esophagus, which is the esophageal phase. So these are the three phases of swallowing, is oral, then pharyngeal, and lastly we have the esophageal phase. Perfect. Moving on to the next question. What do you guys think is the answer? Okay, perfect, exactly. So we have in here achalasia is associated with which of the following at rest and during swallowing. So as we know, achalasia is basically we have basically an increase in pressure, which is basically an abnormal increase in pressure at the end of the esophagus in the lower esophageal sphincter that basically decreases the amount of food to be all the way entering from the esophagus to the stomach. And why this thing happened? Because, as you guys kindly said, the correct answer is number one. We have higher than normal pressure at the lower esophageal sphincter, and I have here a diagram. So basically, as we can see, to just get oriented, this is the esophagus and this is the stomach in both pictures. Normally, this is the esophagus, it's patent or it's open, and then we have the stomach. So the food comes all the way from the esophagus and then goes all the way to the stomach. This is normal. Now, once we have an increase in the pressure at the lower esophageal sphincter, so basically we have two sphincters, the upper esophageal sphincter and the lower esophageal sphincter. And as they always say, if we have lower esophageal, that means we have upper. For example, if we have up, we have down. If we have lower, we have upper. Okay, so as we know, and here we have the lower esophageal sphincter. So usually this lower esophageal sphincter should be open. Why? For the food to be all the way coming from the mouth to the pharynx to the esophagus. From the esophagus, it should all the way go to the stomach. If we have an abnormal pressure in the lower esophageal sphincter in this part in here, and it's a bit constricted, or sometimes it's fully constricted, this will prevent the food from all the way coming from up to down. And if this food doesn't come down, that means the person, other than having weight loss and everything, the person will actually feel nausea and will keep having the vomit reflex. Okay, so I have here another picture. Okay, so as we know, this is, for example, normally this is a bolus of food. It all the way goes from the esophagus to the stomach. If we have achalasia, it's basically one of the esophageal disorders, to be more specific, at the lower esophageal sphincter, and it's a bit constricted because of high pressure in it. So the patient will basically present with difficulty swallowing. We're gonna also have regurgitation. Regurgitation means like a reflex of moving from downward to upward. Tamam. We're gonna have regurgitation, and we might also have chest pain. Okay. So once we have chest pain, like sometimes when we hear chest pain, we will think it's something related to cardiac or cardiac related abnormalities. But let's put in mind that in the chest we have the heart, we have the lung, we have the esophagus, like we have some of the GI tract. Okay, so chest pain isn't always like heart related disease. Like it can actually sometimes present with the GI system, like in this case, the achalasia. Okay, so in here I have this is basically an image of a barium swallow. This patient basically just drank some of the barium. Okay, and as we can see here, this white thing is the esophagus, and as we can see in here, this is still the continuous of the esophagus, and this is the stomach. So what happened in here? This is like one of the tests to just help in confirming the patient who has achalasia, is that we give the patient barium swallow, like barium, and then the patient swallows the barium. And once we do this X-ray image, we will see that the barium suddenly in here stopped. As we can see, this is a line in here, very minor, like very minority of barium that actually like moved onto the stomach, right? So this is like one of the tests to confirm that the patient has achalasia. As we can see here in the lower esophageal sphincter, there is a very big constriction that doesn't allow the barium to move all the way to the stomach. And this sign is called as a bird beak sign. It looks like the beak, this is an inverted triangle, and it looks like the beak of the bird. So it's called the bird beak sign. And this is one of the signs of achalasia. Okay, I hope inshallah it's clear. So moving on to the next question. What do you guys think is the answer? Okay, perfect. Amazing. So the question says the primary purpose of migrating motility complexes is basically which of the following. So migrating motility, as we know, the GI system should have peristalsis for the food to be moving from the esophagus to the stomach, to the small intestine, to the large bowel, and then to the outside of the body. So in regards to this migratory motility, it's basically like the main function is to sweep the undigested residue toward all the way the colon. Exactly. It can also sweep anything basically in the GI tract, either food or any other thing in general. It's going to definitely be moving it all the way to the end of the colon. Perfect. So basically here we have this just slide supports the answer. So we have mass movement. Mass movement is basically it's like peristalsis. So we can say either mass movement or peristaltic movement. And this movement, as we said, is going to basically help move the food from the esophagus all the way till the end of till the end of the GI tract to the colon. Tamam. And this will just aid, this is basically a normal thing that happens in all individuals, in all normal individuals, for the feces to be all the way excreted to the outside of the body. Perfect. Moving on to the next question. What do you guys think is the answer? Excellent, ممتاز. So the question says, most of the acid response to a meal occurs during which phase? So basically we have, for swallowing, we have three phases: the oral, the pharyngeal and the esophageal. We also have other phases in the body, as you know, like this is medicine, so we have many phases, many things. So in general, so basically, for the phase here, it basically asks about the phase where the acid is gonna be mostly be produced, and as we know, it's gonna be produced mostly in the gastric phase. So as we said, gastric is basically stomach, is another name of the stomach, صح? So the acid is gonna be mostly be produced once the food reaches the stomach. This is the most phase where we actually need the acid production, and this is called the gastric phase. Okay, perfect. Moving on to the next question. You guys think of the answer? Perfect. Excellent. Any other guesses? Yes, salam alaikum. Exactly. So this question says, which of the following weakens the gastric mucosal barrier? Usually, if we have, for example, in the stomach, we have basically produces mostly HCl. We have also in the stomach a layer that protects the stomach epithelium from the acid, which is basically the mucosal layer, right? So we have different layers in the stomach to prevent the acid all the way to be penetrating it, because we don't want to have ulcer, which is an abnormal thing. Okay. So basically the bile salt is gonna be usually available. Any alkaline environment is usually available in the duodenum or in the small intestine in general. So if we have this bile salt all the way in the gastric or in the stomach, it's gonna definitely be weak, gonna disturb the pH of the stomach and cause weakness and abnormalities. Okay, is it clear? And as we agreed before, usually the stomach pH is low because it's acidic. Compared to the small intestine, it's usually high pH because it's more to alkaline environment. Okay, is it clear? Okay, perfect. تمام. So as you can see in here, this is basically a just showing the liver, the part of the small intestine, and the pancreas. So as we know, in the stomach, we have some of the cells that basically produce acid-related secretions. Now, once the food reaches to the small intestine, we will have more into the alkaline production, and this basically production happens from different cells from the pancreas, and basically those secretions come from the pancreas, as we can see in here, and also all the way from the gallbladder. The pancreas and the gallbladder, both ducts are going to open into the duodenum, and it's mostly alkaline environment. So that because it's most alkaline environment, because the duodenum and the small intestine doesn't prefer to have acidic environment. Why? Because it doesn't have the protective layer like the stomach has the protective layer. So the stomach has protective mucosal layer against the acid. But the small intestine doesn't really have this layer against the acid. Because of that, it doesn't tolerate low pH, or it doesn't tolerate an acidic environment. Okay. So moving on to the next question. Perfect. Excellent. Yes, salam alaikum. Exactly. So this question says, which of the following is critical for stimulating a bicarbonate excretion from the pancreas? So as we said, pancreas, gallbladder, anything that's going to be the duct is going to open in the duodenum or in the small intestine in general will be alkaline, or will be alkaline environment, like bicarbonate and everything, because we don't prefer anything that has acidic environment. So it's wrong because it's not really related to the acidic and alkaline environment. B is wrong. C is wrong. Gastrin, it produces acid. So this question doesn't actually ask about acid, it asks about bicarbonate. So the only correct answer is secretin. And secretin is basically produced from the S cells that's basically available in the duodenum. So as you can see in here, this is also a section that shows the pancreas and part of the duodenum. The duodenum is basically four parts, okay? So we can see in here some part of the duodenum that basically has a different type of cells, and one of the cells that actually help in secretion of the bicarbonate is the S cell that is basically secretin, okay? Moving on to the next question. What do you guys think is the answer? Okay, perfect. Perfect. So this question says, which of the following can damage the gastric mucosal barrier and stimulate the gastric acid secretion? So if you have any abnormal thing, that's like a pathology, this will basically cause a like disruption or abnormality in the gastric mucosal barrier, right? Right. So bile salt, we have number one, bile salt, number two, the epidermal growth factor, gastrin, and the mucus. Those things are basically available in the GI tract, right? Right. Usually, if you have H. pylori, or in other words, Helicobacter pylori, this is something abnormal, and like normal individuals doesn't really have activated H. pylori. So if we have this thing, the activated H. pylori, this is definitely abnormal and will cause many pathologies in the stomach, duodenum, and the GI tract in general. Okay, so as you can see in this picture, if we have, this is basically the esophagus, this is the duodenum, so, and this is basically the stomach. So if we have any abnormality in the stomach, in other words, if you have the H. pylori, it can definitely by time cause ulcers and cause abnormality in the epithelium of the stomach, okay? And it will affect the gastric mucosal barrier. Okay, moving next. Okay, perfect. Any other answers? Any other answers? Okay, so you guys answered correct. So basically, this question says we have a 48-year-old man with recurrent history of a strong family history of duodenal ulcer disease that's basically suspecting to be having Zollinger-Ellison syndrome. Okay, and in other words, gastrinoma. So we have secretin was given as a rapid intravenous injection to test for gastrinoma. Which of the following result supports the existence of gastrinoma after secretin administration? And as you guys said, the correct answer is number two, which is basically increased serum gastrin. So this question says that we have a patient who has the ZES, which is the Zollinger-Ellison syndrome. What is this syndrome? I just have a picture in here. So this syndrome is basically, it has another word of very high increase of acid or very high increase of the HCl, and it's a triad of three things. All three things just support the phenomena of having very high increase of gastric acid or of HCl. So here we have number one, we have the pancreas and the duodenal tumors can have HCl cells and increase very high amount of HCl. This is number one. Number two, we can also have the peptic ulcers. This is number two. And number three, we can also have the gastric hypersecretion. So all those three things, if all those three things can produce HCl or acid, and this very high acid is going to cause for us a syndrome which is called as the Zollinger-Ellison syndrome or gastrinoma. So so basically the question asks if we have, for example, this Zollinger-Ellison syndrome, and we gave secretin, what can really support that this patient has the gastrinoma? Or gastrinoma basically means excess gastric secretion. So what can support this thing is that we have a very high increase in the serum gastrin. Okay, perfect. Moving on to the next question. Okay, mashallah, you guys are really fast. I like it. Okay, perfect. So this question says an 87-year-old farmer has a breakfast of eggs, bacon, and ham, grits with cheese, fried potatoes, biscuits with syrup, buttermilk, and coffee. Which of the following hormones is released by the presence of fat? Because now it's just say the presence of fat and protein in the small intestine and help to decrease the gastric emptying. Once we hear fat and protein, immediately the first thing that clicks exactly بالعافية. Okay, so the first thing that clicks to our mind is that we will have cholecystokinin, CCK, because CCK will significantly is one of the hormones that significantly helps in the production in the metabolism of the fat and the proteins in the small intestine. And CCK, if it's going to be produced in the small intestine, do you think it will be alkaline or acidic?
Can you repeat the question, please?
Yeah. So basically, if CCK is going to be produced in the GI tract, do you think it's going to be alkaline or acidic?
It's probably going to be alkaline.
Perfect, exactly, because it's going to be mostly produced from the small intestine. Excellent. Okay, so as we can see in here, TCK is going to be produced in different parts in the GI tract, mostly in the small intestine. It can also be produced in different parts of the GI tract, and it helps significantly in the metabolism and digestion of the fats and the proteins. Amazing. Moving on to the next question. Okay, perfect, amazing. So, mashallah, you guys are answering everything correct. So that's really amazing, mashallah. So here the question says, a 67-year-old man has heartburn and stomach pain. Endoscopy shows several small gastric ulcers in the corpus. Biopsy were positive for H. pylori or Helicobacter pylori, which promotes gastric ulcer formation by damaging which of the following. So you guys said it's going to be, of course, the gastric and mucosal barrier. Just remember, if we have any abnormality in the GI tract, to be more specific in the, for example, stomach, duodenum, any abnormality, to be more specific in the stomach, it's going to definitely, or any abnormality, any pathology, any disease, any abnormal thing is going to definitely be affecting the gastric mucosal barrier. And if this barrier is basically affected, it will aid in many abnormalities in the stomach, starting off with ulcer. We can have peptic ulcer. If the ulcer is really chronic and it isn't treated properly, or it isn't treated aslan from the first place, it can definitely cause for us perforation, like from the ulcer, from a mini hole. This hole can keep invading inside the stomach layers from inside to outside till it all the way cause for us perforation. So it's really very important to like treat immediately any of the pathologies or abnormalities that can cause the gastric mucosal barrier insufficiency or abnormality. Okay, so we have in here, this is basically the gastric mucosal barrier. This barrier is basically available in the stomach, and it's mainly, as we said, the environment of the stomach. It has a low pH and it's mainly acidic. If this barrier has any disruption, if it's broken, if it has any pathology or any abnormality, by this, the acid will all the way be diffusing to the diffusing, and the mucous membrane is going to be, or the mucosa is going to be affected, which will all the way help and aid in the formation of ulcer. And if this ulcer isn't treated, it will cause for us perforation and way many more consequences, bad consequences. Okay, so also we have in here, this picture basically supports the just shows the mucosal barrier, how it looks like, and it's basically having 3 layers. Okay, so moving on to this next question. What do you guys think is the answer? Okay, perfect. Any other guesses? Yes, salam alaikum. Exactly. So this question says a 55-year-old man presents with abdominal pain, and the abdominal examination were relatively benign, and it was okay, normal. But we have some abdominal radiograph that suggested a perforated viscus. Now, this endoscopy, it revealed for us chronically perforated gastric ulcer. So it's perforated gastric ulcer. And we said first, the stomach, if there's any abnormality, it can have an ulcer. If this ulcer keeps on for a long period of time without being treated, or without being treated like in an efficient way, it's gonna be perforated. Because of that, here it says a chronic perforated, because any ulcer that's perforated, that means it's been chronically untreated. Because of that, here it says chronically perforated gastric ulcer. So now you know, like, what does this word really mean? Okay, so if we have chronically perforated gastric ulcer, then through which the liver was visible, which of the following is forerunner to the gastric ulcer formation? Of course, this will be a problem in the hydrogen ions, and the hydrogen ions is going to be all the way is one of the causes for this ulcer to be formed, because we have abnormality in the barrier layer. So the correct answer is back leak of the hydrogen ions. As we know, the mucus secretion, if we have if a good mucus secretion, we won't have this chronic gastric ulcer and all of these abnormalities. And the proton pump inhibition, this doesn't have anything to do with this scenario. Same goes to number 4 and number 5. So the correct answer, as you guys kindly said, is number 1. Perfect. Moving on to the next question. Okay. Any other guesses? Exactly. Yeah, I get your point, don't worry. Okay, perfect. Excellent. Yes, salam alaikum. Exactly. So when does the pH of the gastric content reach to its lowest? So as we know, the pH of the stomach is the lowest amongst all the GI tract, and this is useful and very beneficial for the whole GI environment because we want the food to be digested well. We also want any of the organisms because usually when we eat something, sometimes it has organisms like bacteria, fungi, maybe or any other organism. So you want this. Usually, sometimes we eat, for example, let's say a food that are already expired or something, and sometimes we are okay, like we don't have, for example, any gastritis or any like a gastroenteritis, or like we are normal. Why this thing happen? Because our body other than the defense mechanism and other than immunology that the body, like our body, basically defend ourselves in, the acid, the low pH in the stomach, or in other words, the acid, the very high acidic environment kills this bacteria or kills this microbe or kills the organism. So this is actually one of the reasons why sometimes if we ate something expired or something yani, bad, we won't really be affected. And this is because of the very low pH of the stomach. And as you guys kindly said, the gastric content, if it reaches the lowest level, it's going to be after 4 hours. So once we eat, as we said, in the gastric phase, the pH is going to be the lowest, and we have very high production of HCl. This is what we need so that if there's any microbes, it's going to be hopefully, inshallah, dead. And also this aids the low pH or the high acid in the stomach, help aiding in the digestion of the food, right? Right. So after the food is digested and خلاص يعطيك العافية يا stomach, you're done with your job and everything is okay. So the pH or the HCl usually يعني levels keep on decreasing, and this decrease usually happens in approximately 4 hours after you've eaten your meal. Okay, so once you eat your meal, the meal reaches the stomach. This will be the gastric phase, very high HCl production, and the pH will be low, and everything is good. خلاص خلاص. After 4 hours, approximately 4 hours, خلاص the usually the pH content is gonna be all the way to its lowest. Okay, perfect. Moving on. Do you guys think of the answer? You can take your time. Yeah, salam alaikum. Exactly. Excellent. MashaAllah, exactly. So this question says a 30-year-old woman visits her physician because of abdominal bloating, excessive flatus, and diarrhea. And basically, the physician notes that there's absence of surgical scar during physical exam. All of those things we don't really care about a lot. We care. The result of 72-hour stool collection indicates excessive amount of fat. This is the most important information. We have very high amount of fat in the stool, and 90% of the stool fat consists of triglyceride. So usually we don't really have this very high content of fat to be in the stool. So this is considered to be abnormal and very high, right? So here it says which of the following best describes the nature of this patient's problem. Now, usually the pancreatic enzymes significantly helps to digest the fat, right? So the fat, the protein, everything. But yani in this case, in this scenario, we're talking about the fat. So if we have any abnormality in the pancreatic enzyme, lipase, like the lipase that's produced from the pancreas, this significantly helps in indigestion of the fat. So if we have indigestion of the fat and nothing is basic, there's no enzyme that digests this fat, where will the fat go? It will all the way go to the stool because it's not digested in a way that the body can absorb this fat content. So if this fat all the way go to the stool, we will call it as steatorrhea. This steatorrhea is basically the name or the medical name or medical terminology of excessive fat that's going to be available in the stool. So as we said, steatorrhea is basically the presence of excess fat in the feces or in the stool, and we have way many more causes of the steatorrhea to happen, either because of the pancreatic enzyme insufficiency, the pancreas isn't really producing enough enzyme or to digest this fats like the lipase, or is not also producing enzymes in the first place. Maybe if you have chronic pancreatitis, if you have celiac disease, and many other diseases. Okay, so this basically can help in the production of fat into the stool, and this is considered to be abnormal. Perfect. Moving on to the next question. Okay. So guys, this is the last question with me. Like we're gonna discuss together but from my part, and then my friend is gonna discuss فايش rethink of your answer. So this question asks about triglycerides. Maybe a couple of answers can be correct, but what's the most answer that can be correct in those choices? Okay, so we're going to do it together. This question says, which of the following enzymes is especially active in the capillary endothelial and hydrolyzes the triglyceride and chylomicron? So triglyceride is basically a fat, right? Right. So which of them will be basically hydrolyzing the triglyceride of the chylomicron? I'll just show you the figure and then we're going to come back to this. So we can see here in this picture, as we can see in here, we have in here the chylomicron, and we have over here, we want the lipid to be digested. So what's the enzyme that's going to be used? Lipoprotein lipase, okay? So once we have this chylomicron that we want it to be, the enzyme that we're going to use for it is basically going to be the lipoprotein lipase. Okay, let's come back to the question and the choices to discuss more about it. Here it asks about what will basically help in hydrolyzing the triglyceride of the chylomicron. Type. Triglyceride is a fat, right? Right. So any enzyme that has fat can actually like hydrolyze this triglyceride, because here we have the lipase. So starting off with this thing, it doesn't really have a role. Lingual lipase doesn't really have a role, right? Right. Lipase, okay, lipase is lipid, so maybe it has a role. Lipoprotein is lipid protein, so okay, it has a role. Pancreatic lipase, yeah, it has a role. So lipase, lipase, those are three things like helps or aids in the digestion or the hydrolyzation of the triglyceride. But for to be more specific, in the capillary endothelial thing that helps the hydrolyzation of the triglyceride of the chylomicron is going to be number 4, which is the lipoprotein lipase. And basically, this figure just explained how it happens. As we said, this is the chylomicron. We use this enzyme, which is the lipoprotein lipase, and it helps all the way in the hydrolysis of the lipid. Okay. Okay, just reading your questions. Okay, so yeah, so basically, as we said, we have different enzymes to digest or to hydrolyze the lipids. Either we have different things. Maybe we have also more than those three things to hydrolyze the lipid in general. But for this question, exactly the correct answer is basically 4. And as we said, this figure actually showed you that the chylomicron we're going to use for it the lipoprotein lipase. But generally speaking, for different, we have many enzymes in general to digest the lipid. Yeah, of course, we have many enzymes to digest the lipid. Okay, is it clearer? Okay, perfect. Guys, any questions or there's no questions? Now I'm done with my part, and inshallah my friend will start off and carry on to other questions. So I just want to make sure, do you guys have any question? You're most welcome. Okay, that's amazing. If you guys have any question anytime, you can basically just call me anytime you would like, just text me WhatsApp, or if you have anything in general to discuss either in this lecture or any other lecture, I'm more than happy to either discuss on WhatsApp, or if you want to meet face to face, I'm of course more than happy to help. And I'm very proud of you as inshallah amazing future doctors. So all the best of luck inshallah, and الله يعطيكم العافية ويوفقكم ويوفقنا جميعا إن شاء الله. I guess my friend can start.
Should we take a break first? Maybe for like Salah, like 10 minutes?
I don't mind, to be honest, as you like.
Okay.
Sure, we can have 10 minutes on a break and then come back. Now it's
Okay.
8, so at 8:10, inshallah, we can resume. Okay, guys?
Okay, perfect.
You can stay in this Zoom meeting, okay?
Perfect. Okay, I'll start now. Hi everyone, I'm Bushra Rasheed. I'm a 5th-year medical student, and I'm going to be taking over for the remaining physiology practice questions. Thank you to Lara for such an amazing session. I'll be taking over from here. I've listed my email address and my phone number in case you have questions after the session and you'd like to reach out. I'm open to WhatsApp and I'm open to email. Anything that you like, you can reach out before your exam. Okay. All right. A 49-year-old male patient with severe Crohn's disease has been unresponsive to drug therapy and undergoes ileal resection. After the surgery, he will have steatorrhea because. So before we move on to the options, I want to give you guys some peace in knowing that you're not supposed to know what Crohn's disease is. What's important in the stem of this question is that he's undergone ileal resection. So he no longer has his ileum. We need to know why he's having steatorrhea. Is it because of his liver bile acid pool, which has increased? Is it because the chylomicrons don't form in the intestinal lumen, or the micelles don't form in the intestinal lumen? His dietary triglycerides cannot be digested, or the pancreas do not secrete lipase. Okay, C. The answer is C. So there is no micelle formation in the intestinal lumen. Now let's look at why that is. So his terminal ileum, his ileum basically is resected. And we know that with ileal resection, this is a screenshot of the lecture, of the slides where this is mentioned, just so that you guys know for reference. Okay, so when the patient's ileum is resected, the majority of his bile acids are not going to be reabsorbed into the ileum. We know that the ileum is the site where the bile acids are reabsorbed. They enter the circulation and they get circulated back to the liver so that new bile acids can be secreted, right? When the ileum is resected, that's not going to happen. Most of the bile acids are now instead going to be secreted in the feces. And so the bile acid pool has decreased, right? In that case, you're not going to be forming micelles in the intestinal lumen. Micelles are very necessary for lipid solubilization and absorption of the lipids. And so when the lipids are not absorbed by the enterocytes, they're going to be excreted in the feces and you're going to have fat in your stool. The other options are wrong because liver bile acid pool is obviously decreasing. It's not increasing because you're secreting so much in your feces. Chylomicrons do not form in the lumen, they form in the enterocytes. So automatically this option is wrong. There's nothing wrong with triglycerides in this scenario, and the pancreas, again, the pancreas are perfect. There's nothing that's wrong with them. The problem is in the ileum and not in the duodenum, so we're not even thinking of the pancreas in this situation. Okay. A 44-year-old man severs his spinal cord at T1 in an automobile accident that leaves him paraplegic. So his spinal cord is severed, and paraplegic means that he's completely paralyzed. Again, these aren't things that you're supposed to know in detail. Usually when you have a very long clinical vignette like this, the first thing that usually we're advised to do is read the last sentence, okay? So reflex relaxation of which structure occurs as defecation reflex is stimulated. You realize by reading this last sentence that you don't even need to read the full vignette. I would advise you to, and you should definitely read it once, but reading the last sentence is going to give you like a flavor of what to expect, right? So he has chronic constipation, and his physician advises him to distend his rectum digitally. Digits as in fingers, so he's having to distend his rectum with his finger on a regular basis to initiate the reflex, right? So reflex, a relaxation of which structure occurs as the defecation reflex is stimulated. D. Absolutely, the internal anal sphincter. Let's go over this. Let's go over a summary of defecation. Okay, so when you have mass movements in your distal colon, the defecation reflex is stimulated. Whenever the feces are in your rectum and there's distension of the rectum, the pressure receptors in the rectum are stimulated. That is when the defecation reflex gets activated. What happens when the defecation reflex is activated? You're going to have contraction in the rectum, right? Because it needs to squeeze the feces out. You're going to have a reflex relaxation of the internal anal sphincter, and then contraction of the external. So this contraction will occur the moment you feel the urge to go. Of course, wherever you feel the urge to go, you're definitely not gonna go right there, right? You're gonna want to hold it in before you can go to the bathroom. So when there's an increased pressure in the rectum, you can either defecate, you're gonna first contract the external anal sphincter. Of course, you're not gonna go at the time at the place, you're gonna go to the bathroom and then initiate the defecation, or you can delay. If there's no bathroom near you, you might want to delay. In the event that you want to delay, you're going to consciously, like voluntarily, contract the external anal sphincter, and the puborectalis muscle will also get contracted. So now the rectum is not at the anal angle, sorry, is not at the most ideal angle to defecate. There is reverse peristalsis in the rectum, so the feces get transported back into the sigmoid colon. However, if you're in the bathroom and you're like, yes, I'm ready now, relaxation of the external anal sphincter will occur. Again, it's a striated muscle, so this is under voluntary control. Relaxation of the puborectalis muscle will take place. forward peristalsis in the rectum. So all the sigmoid colon is going to empty into the rectum. And then lastly, you can do the Valsalva maneuver, which is squatting, if you want to, you want help with defecation. Okay. Mass movements are often stimulated after a meal by distension of the stomach and distension of the duodenum. Mass movements often lead to which of the following? Bowel movements, gastric movements, haustrations, esophageal contraction, or pharyngeal peristalsis? A, bowel movements. You're right, so bowel movements. Okay, let's look at the slide for this. So there's two kinds of movements that occur in the colon. We have the proximal colon and then we have the distal colon. Yeah, you guys can see my mouse, right, when I'm explaining?
Oh, yeah, we can see it.
Okay, thank you. So in the proximal colon, something called segmentation takes place. And what that essentially is it's erratic contractions. This is not peristalsis where you have relaxation behind the bolus and then you have contraction in front. This is erratic, as in contractions are occurring randomly. There's just random contractions occurring. This is good in a way because the proximal colon is where the fluid and electrolytes are getting absorbed back into the body. So you just want to mix around the bolus of food so that the maximum to increase the surface area to increase the absorption of fluid and electrolytes. And because of the erratic movements, it's slow. The food is not going to just go into the distal colon. But the distal colon is where the peristalsis takes place. These are giant contractions. This is what mass movements refers to. So this is where you're going to have contraction behind the bolus, behind the feces, and you're going to have relaxation in front of the feces. And so the feces are going to get pushed down. This is where you need movement to occur. The proximal colon is where you need still reabsorption is occurring, and this is where movement occurs. So these are mass movements. And this will transport the feces all the way to the rectum. Okay, which of the following occurs during the act of vomiting? So what happens to the lower esophageal sphincter, the upper esophageal sphincter, abdominal muscles, and the diaphragm? D. Absolutely.
D.
Okay. So yeah, thank you. The lower esophageal sphincter is going to relax. That's how the vomitus moves up. The upper esophageal sphincter also relaxes. That's how the vomitus is going to move out of the mouth. And both the muscles are going to contract. Let's look at this in more detail. So you have reflex contraction of the abdominal muscles and the diaphragm. And this is when your stomach is getting squeezed against the diaphragm, so it increases the intragastric pressure. This is increasing the intra-abdominal pressure, right? The lower esophageal sphincter opens. Chyme moves all the way to the esophagus, but this is still, the upper esophageal sphincter is still closed right now. What happens is that the abdominal muscles and the diaphragm contract to a point where the intrathoracic pressure is so high that this pressure overcomes the pressure of the upper esophageal sphincter, right? So we've overcome the pressure, and the upper esophageal sphincter is just going to open on its own, and the vomitus will be ejected, from the mouth. Obviously, the glottis will be closed. You're not going to be breathing when you're vomiting, of course. And this is good in a way because you're not getting any contents into your trachea. You're not going to get aspiration pneumonia because of this, which is good. Okay, next question. A 35-year-old woman adds lots of high-fiber wheat and bran fruits to her diet to reduce her cholesterol level. She has avoided eating wheat or rye foods since she was a child because her mother said they would make her sick. She loses 30 pounds on her new diet, but it has a number of undesirable side effects, such as stomach cramps, she is bloated or she's very gassy, and frequent diarrhea. She also has become weaker, finding it difficult to complete her morning walks. Her gastroenterologist diagnosed a malabsorption syndrome called celiac disease. Which of the following is the most likely to be increased in this woman? So, is it the blood hemoglobin concentration, the carbohydrate absorption, protein absorption, serum calcium, serum prothrombin, or stool fat? F, stool fat. Perfect. Stool fat. Okay, so let's quickly go over what celiac is. So gluten-sensitive enteropathy or celiac is basically when you have a hypersensitivity to gluten, right? This is going to cause all of your villi to undergo atrophy. So you're going to have villus atrophy. You have a loss of surface area because the entire purpose of the villi is to increase surface area for absorption, right? But these are going to atrophy, so the surface area is now decreased. And you're going to have less transport of food, electrolytes, nutrients into the enterocytes. Because of this, there's still going to be a certain amount of food that's still present in the intestines that is not getting reabsorbed. And so there's going to be some sort of a gradient and the water moves out of the enterocytes into the lumen, right? So this is osmotic diarrhea when there's osmotically active substance, which is present in the lumen right here. And so water moves in from the enterocytes. Yeah, and it causes diarrhea. There's so much water in the food that there's so much diarrhea. Yeah, imbalance between absorptive and secretory fluxes. There's so much less absorption because of the villus atrophy. And the unabsorbed fatty acids, this is what's going to lead to steatorrhea, which is going to be fatty stool. Yeah, okay. Okay, moving on to the next question. Which cell type found in the liver removes nearly 99% of the bacteria found in portal blood? Is it the blood endothelial cells, hepatocytes, Kupffer cells, lymphatic endothelial cells, or smooth muscle cells? Now, this is more of a recall question. This is not so much an application kind of a question. C. Kupffer cells. Perfect. So this is the slide that you guys have, and it mentions here that the Kupffer cells are phagocytic macrophages. This Kupffer cell is responsible, since that's, again, it's a macrophage, it's responsible for phagocytosis of all the bacteria that's going to be present in the portal blood. And so it's going to be responsible for cleaning up the bacteria, the debris, and making sure that the portal blood is nice and juicy. Okay. A 35-year-old woman is admitted to the ER because of severe right upper quadrant pain. She states that her stools are clay-colored and her urine is dark orange. Physical examination shows an enlarged liver and icteric conjunctiva. Lab results show elevated serum bilirubin levels. Absorption of bile salts is most likely decreased to the greatest extent at which of the following locations in this patient? Let's look at the question first. So she has severe right upper quadrant pain. Okay, right upper quadrant pain most likely is because of a liver etiology, or it can be gallbladder. These are present in the right upper quadrant, and most likely this is where the problem occurs. She has clay-colored stools, and her urine is dark orange. Now, this is, I'm going to explain why she has this, but this is very, very pathognomic for a certain condition, okay? She has hepatomegaly and icteric conjunctiva. Icteric refers to yellow conjunctiva. So she has jaundice and she has elevated bilirubin levels, okay? Where is the absorption of bile salts decreased the most? D. Yes, absolutely D. So this is where terminal ileum, or the ileum itself, is where the absorption of bile salts occurs the most, right? So it's very important for us to know this. Yeah, and let me move on to why she has the clay-colored stools. I'm just going to touch on bilirubin metabolism really quickly. So you have a red blood cell that has hemoglobin. The red blood cell is lysed. It's for a multitude of reasons. Most probably it's at the end of its 120-day life cycle, the red blood cell is going to get broken down. Hemoglobin is released, right? Hemoglobin gets broken down into heme and the iron and globin. Globin is just a protein. It's going to get broken down into amino acids. They're going to get recycled, reused, whatever. Then we have heme. Heme gets converted to biliverdin, which gets converted to bilirubin. All of this occurs in the macrophage. And then the bilirubin is going to get attached to albumin, which it will take to the hepatocyte. The bilirubin is conjugated, released into the canaliculi, and then it's secreted into the intestines, okay? And then this is where unconjugation occurs, etc., etc. In this patient, no, sorry, let me go over the rest of it. This bilirubin will form urobilinogen, stercobilin, and this stercobilin is what will give feces its characteristic brown color. Bilirubin will also form urobilin, and this is what gives urine its characteristic yellow color. In our patients, we know that she has clay-colored feces, so there's no pigment in her feces, and her urine is super dark. Her urine is dark orange, so it's super, super dark. Most probably what occurs, again, they don't mention the etiology, but we know that most probably there's some sort of a problem that is occurring in this level, okay? At the level of the bile duct. Either there's gallstones, maybe there's biliary cirrhosis, or there's some sort of a problem where the bile is not going to the intestine. It's not getting excreted into the duodenum. It's instead going to the blood. That's why when none of the bile acids are in the stomach, we have this deficiency of stercobilin, and so the stools are no longer brown. They're clay-colored. And instead, all the bile is getting excreted into the blood, the bile acid, And so we have a lot of urobilin, we have a lot of pigment in the urine, and the urine itself is really dark yellow colored. I know this is not what the question asked. They want to know where exactly bile acids are reabsorbed. But I just wanted to explain to you that whenever you have a question where they say that the stools are clay colored or the urine is super dark, immediately your brain should be thinking that there's some sort of a problem that's occurring at this level, which is why there's a lack of pigment in the stool and there's way too much pigment in the urine. And yeah, the bile acids get absorbed into the ileum. This is a very crucial fact that you're supposed to know. Which of the following is a likely consequence of ileal resection? There's a lot of ileum stuff going on in the questions. Okay, what do you guys think is the answer for this? Achalasia, atrophic gastritis, constipation. Sorry?
E, since there will be less vitamin B12 absorption.
Exactly, perfect, absolutely. So let me just go over the pathway really quickly. When you have B12 in your diet, it's most likely connected to some sort of a protein. You're going to ingest it. Because of the hydrochloric acid, it's going to get dissociated from the protein. Now this B12 gets bound to haptocorrin. Haptocorrin takes it all the way down here, which is when the pancreatic proteases are going to break it down. And yeah, the pancreatic proteases are going to break it down. And so now you have B12 on its own. It's going to bind to the intrinsic factor and get reabsorbed into the terminal ileum. Now, there's a multitude of reasons why you can have pernicious anemia. Either you have something wrong in your stomach, right? This is where intrinsic factor is released. So if you have something like gastritis or atrophic gastritis where the mucosa is not functioning properly, you're not going to produce intrinsic factor, so you're not going to absorb B12. Or you can have, in this case, ileal resection, which is the main site of ileum reabsorption, of the intrinsic factor B12 complex reabsorption. So if you don't have this portion of your small intestine, B12 is not going to get absorbed and you're going to get pernicious anemia. Okay. A 10-year-old boy is admitted to the emergency department because of severe watery diarrhea after consumption of polluted water. Cholera is suspected and later confirmed by the presence of Vibrio cholera in the stool. The diagram shows a secretory cell in the crypt of lubricant of the small intestine. Cholera toxin exerts its effects by causing a primary upregulation of which step in the secretory mechanism. So, this is A, we have B, C, D, E. Which of these do you think is upregulated by the cholera toxin?
Does it upregulate means it stimulates even more?
Exactly, yeah.
Cyclic AMP.
Perfect, E, absolutely. So the toxin that's produced by cholera, which is cholera toxin, binds to a protein that's known as GM1 or glycolipid membrane receptor 1. And this is present on the entire chromaffin cells, right? What's going to happen is that the cholera toxin gets endocytosed after binding to the receptor. It's going to cause a sustained release of cyclic AMP, which is going to increase the amount of serotonin that's released by the cells. This serotonin is going to stimulate the afferent nerves, which will increase the amount of VIP or vasoactive intestinal peptide that's released into the crypt cells. So the enterocytes are going to increase its secretion of chloride into the lumen, which causes persistent watery diarrhea. Other than an increased chloride secretion, we also have a decreased sodium chloride absorption. So both of these actually facilitate the etiology of watery diarrhea. This is why the patient will have really, really persistent diarrhea. Okay. A 19-year-old female visits her physician because of nausea, diarrhea, lightheadedness, and flatulence. Flatulence is being very gassy. The physician administers 50 grams of oral lactose at time 0, which according to the graph would be right here, and measures breath hydrogen every 30 minutes for the next 3 hours using this handheld monitor. The results are shown below. Which of the following best describes this patient's condition? So as you can see, the hydrogen level is periodically increasing in the patient's breath. Is it a brush border lactase deficiency or brush border lactase excess?
A.
Pancreatic. A. Yes.
I have a question. Would that mean that there will be less glucose?
Sorry?
Like if someone tested positive for lactate deficiency, he would have less glucose than a person without, right?
Can I get back to you after the presentation with this question, if that's okay?
Tamam.
I think I don't fully understand the question. Let me just get back to you. Do you think you can write it in
Tamam.
the chat, if that's okay?
Tamam.
Okay, thank you.
If I may, I think I have an answer for that.
Okay.
I did read somewhere that in a lactase deficiency, since the body can't exactly absorb the sugars in lactose,
Mm.
it's not going to have any effect on blood sugar. So that may be what my friend Yasa is referring to.
Does that answer your question?
I mean, but this contradicts some things. يعني according to slide, we would have since lactose is not converted into glucose and galactose,
Mm-hmm.
I think there will be less glucose due to the fact that lactose cannot get broken down.
I mean, compared to a normal person, I'm sure the glucose is less, but I don't think it's because glucose is absorbed in a lot of other forms too. You don't just have lactose, you also have sucrose, you also have the other sugars. So I don't think that glucose would decrease significantly. But I'm not 100% sure. I can read up on this and I can get back to you
تمام.
with the proper answer. Okay. All right, moving on. Okay, so yeah, the lactose intolerance test or the hydrogen breath test, this is what you would do when you suspect that there's lactose intolerance in the patient. You're gonna give them lactose and then you're gonna measure the amount of hydrogen that they're expiring out. The way that this works is the lactose, because there's no lactase, it's not gonna get converted to galactose and glucose. And so it's just gonna get passed on to the large intestine as lactose, and then the bacteria feeds on this. So when the bacteria digests lactose, it's going to release a lot of metabolites, things like acetic acid, things like lactic acid, carbon dioxide, and hydrogen. The carbon dioxide is what's characteristic for, it's going to cause a lot of bloating and gassiness. Because of the presence of acids and because of the presence of other metabolites, you're going to get diarrhea. Because it's osmotically active substances, water is going to go in. And then when you're losing so much water in the diarrhea, you will also have dehydration, right? And this is the hydrogen that's measured in the breath test. Okay, so I just wanted to come on here and quickly explain the difference between hydrogen breath test and the lactose intolerance test. So I know one of our colleagues asked the question, like the levels of glucose, will they be affected or not? And I think that you need to first understand the difference between these two tests for you to understand what's going to happen to the glucose levels of your blood. So the hydrogen breath test is basically when they're measuring the hydrogen in your breath, as the name suggests. They're going to give you, the doctors are going to give you 50 milligrams of lactose, and then they're going to measure your breath every 30 minutes for a period of 3 hours. And they're going to measure the amount of hydrogen in your breath. And if it's more than a normal person should have, you most likely have lactose intolerance. There's actually a second test as well, which is known as the lactose intolerance test. And this is when they're measuring the blood glucose levels. So they're going to give you, once again, 50 grams of lactose, and they're going to measure your blood sugar levels or your blood glucose levels. What's going to happen is if your blood glucose levels don't rise significantly, most probably you have lactose intolerance because the lactose is not getting broken down to glucose. This was the question that again, one of our colleagues asked, and I wanted to clear it up. So yeah, the glucose levels will remain low, whereas if you are a normal person who has lactase, the enzyme, if you're administered lactose orally, you will be able to break it down to glucose, and so your blood glucose levels will rise. I think this is where the confusion arose. It was this slide because they actually mention the hydrogen breath test in the title, and then they go on and give us glucose over here and not hydrogen. So this is where the confusion arose, I think. Basically, when the glucose level is constant in your blood after the administration of lactose, you are most likely lactose intolerant. Negative means that you do not have the lactase enzyme. So when you don't have the lactase enzyme, you're not going to be able to break down lactose to glucose, and your glucose level is going to stay constant.
Whereas if you did have the lactase enzyme, you were positive for the enzyme, your blood sugar level or the blood glucose level is going to spike. And this spike occurs because, again, the lactose gets broken down to glucose, the glucose is going to get absorbed by the bloodstream, and then your blood glucose levels will rise. So these are two different tests. It's very important to know. There's a hydrogen breath test, and then there is a lactose tolerance test. And this graph that they've given here, this is for the lactose tolerance test. I also wanted to mention really quickly that all of my questions and my colleague Lara's questions were from the GIT test bank. Some of my questions were actually from the BRS physiology book as well. So yeah, if you want access to these books, what you can do is go on the there's like this whole resources OneDrive. There's a link to it. I'm sure you guys have that in your WhatsApp groups, like the description. If you go there and you click on textbooks, you can go to the physiology section and look up the GIT test bank. It's present there. The GIT test bank is amazing because it has the answers to the questions as well. And BRS is even better because it has explanations as well. So if you're able to go check these resources out, please do before your exam. And yeah, I wish you guys the best of luck in your exam. I'm sure if you've made it this far, you're gonna ace the rest of it, inshallah. Good luck.
Okay. We're almost done. I think we have 2 more questions left. A 24-year-old male graduate student participates in the clinical research study on intestinal motility. Peristalsis of the small intestine mixes the food bolus, is coordinated by the CNS, involves contraction in front and behind the bolus, involves contraction behind and then relaxation in front of the bolus, or involves relaxation of the smooth muscle simultaneously throughout the small intestine. What do you guys think this is? D. Perfect. So it makes sense. D makes sense, right? Because peristalsis, we're not mixing the food bolus, we're more so transporting the food bolus. We know for sure it's not controlled by the CNS, it's controlled by the peripheral nervous system, under which the enteric nervous system falls under. We're not going to have contraction behind and in front because then the bolus is not moving anywhere if there's contraction in front and behind. And lastly, relaxation of all the muscles throughout the small intestine. That also doesn't make sense because then there's no movement that's occurring if the entire intestine is relaxed. Yep, this is where the question is from. Contraction behind the bolus, and then simultaneous relaxation in front so that the bolus can be propelled forward. This is our last question. Which of the following elements of the defecation process require input from the higher centers of the brain in a healthy person under normal conditions? Peristaltic contractions of the sigmoid colon, rectal distension, rectal paralysis, relaxation of the external or the internal anal sphincter. D. Exactly. So what's really important in this question is for you to understand that higher centers means the cortical centers, which is where you are making conscious decisions or voluntary decisions. This is where whatever is in your conscious control. And out of all of these options, the external anal sphincter is the only thing that you're really voluntarily controlling. The internal anal sphincter is not within your control. Again, you're not doing peristalsis. You're not consciously doing peristalsis. And neither are you distending your rectum in a normal healthy patient, not the previous question like we mentioned. So yeah, relaxation of the external anal sphincter. This is where it mentions that in the slide. The external anal sphincter is under voluntary control. And yeah, I think that's pretty much it. That was around 14 questions, I think. And thank you so much for attending. I really hope that this was of benefit to you guys. If you could just quickly scan the QR code and give us feedback on the session, that would be amazing. Yeah, and if there's anything that you think that I can improve on, or if there's anything that you liked regarding our session, we would love to hear it. Thank you so much. Can you just I forgot, was it Yasser who had the question regarding?
Yeah.
Okay, can you give me your phone number?